So in this very brief video, we are going to focus on a specific adverse drug reaction, being EPS, or extrapyramidal symptoms, which is also known as drug-induced movement disorders, which we actually discussed some back in Block 3 when discussing metoclopramide for the treatment of gastroparesis. And the reason metoclopramide was able to induce EPS was through the blockade of dopamine receptors at off-target sites like in the CNS. And you will see a similar theme with the other agents we discuss in this mini video. So based on what we discussed in the main Parkinson's disease video, it makes sense that if we administer agents that are able to antagonize dopamine receptors in the CNS, whether or not it's intended or off-target, we can throw off that balance, promoting those intended and preventing those unintended movements. And under this umbrella of EPS, we have dystonias, which are unintentional muscle spasms and sustained contractions. We can have akathisia, which is basically restlessness. We can have tardive dyskinesia, which is an involuntary repetitive jerky movement. Or we can have Parkinsonism, with that bradykinesia, that tremor, and that rigidity. And sometimes these are reversible, and sometimes they are not. So outside of metoclopramide, the drug class that is the #1 culprit are the antipsychotics. And one of the primary reasons patient adherence can be challenging. But not all antipsychotics are created equally. So generally the risk of EPS is much higher with the typical antipsychotics that primarily antagonize those dopamine D2 receptors, like Haldol or haloperidol, for instance. The atypical antipsychotics actually have an additional mechanism of action that balances this D2 receptor blockade to significantly reduce that risk of EPS. And we will get into these differences in a later video. So in addition to metoclopramide and our typical antipsychotics, some antiemetics like prochlorperazine also block dopamine receptors and come with the risk of EPS. Now, there are a number of other agents that when combined or in certain patients may lead to EPS, but generally metoclopramide, our typical antipsychotics, and some antiemetics are the most common inducers of EPS. And this discussion is important for this week because a patient presenting with Parkinson's-like features should have their medications reviewed to ensure that this is a presentation that's not due to one of their medications that may have either just been started or the dose increased, or there's some other pharmacokinetic explanation. So moving on to the summary slide. So now if you have a patient with drug-induced Parkinson's, the first step is stopping or reducing the dose or switching the offending agent. And in most, not all, but most cases, there will be a resolution of symptoms. And if there is a need for medications to help, anticholinergics and other Parkinson's disease medications can be used to help, as well as others that we won't get into in this video. So in order to really determine if a patient has Parkinson's or drug-induced Parkinsonism, it will be essential to get an accurate medication history, including any dosing adjustments, and being able to identify drugs with dopamine receptor blocking activity will allow you to make a swift decision to determine if it's truly drug-induced or if it's true Parkinson's, so the patient can receive the treatment they need and avoid unnecessary drug exposure to improve their quality of life.